No sé si son realmente para los niños o para los papás,
¿Verdad?
porque entraña muchos mensajes todas las
De
semanas.
adultos y...
Hola, hola, ¿qué tal? Buenas tardes.
Me acabo de escribir ahora.
Hola a todos.
Buenas tardes.
Hola Félix, ¿qué tal?
Bien, ¿cómo están? ¿Todos bien?
Bien, bien, gracias. Ahí en el chat, no sé si lo alcanzas a ver, pero está una liga de YouTube. Eh, También estamos transmitiendo por YouTube, así que
Ok.
este, para que no haya problema ahí con ese detalle.
Bien, bien.
Sí se compartió bastante, lo compartió Pérez Contreras,
Ujú.
eh, pues con todos los magdalenos. Sauri también le dio algo de difusión. Entonces, pues bien.
También avisé a bastante gente por ahí. A ver, lo que se conecten los residentes, los fellows ahí
Hola,
de
buenas
centro
tardes.
médico. ¿Qué tal, Miguel? ¿Cómo
Buenas tardes.
estás?
¿Cómo están? ¿Todo bien ustedes?
¿Qué tal,
Bien,
Miguel?
bien,
Bien, bien,
Buenas
gracias.
tardes.
bien.
Buenas tardes a todos.
¿Qué tal?
Hola,
Igual, buenas
Libardo, ¿cómo
tardes.
estás? ¿Tienes la presentación del doctor Hwa, Félix? ¿Sí?
No, 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 no. Él no me la mandó. Me dijo que se conectaba y
Ah, ok.
y
Digo,
la
yo
daba.
tengo
Ujú.
aquí, puedo compartir la pantalla para compartir pues su extenso currículum.
Ya
Tengo
se conectó.
el resumen y compartimos algunos de los aspectos más sobresalientes de él.
Ok.
Déjame darle la bienvenida al doctor.
Doctor Geo, hello. How are you?
Good morning. In
Good
South
morning for
Korea, it's
you.
early in the morning. Okay.
Okay. Nice to see you. Thank you. Thank you in advance for
Thank you.
giving us this opportunity to share with us all
Yeah.
your knowledge.
Thank you,
Alfonso.
Dr. Hyodong-hwa.
Yes.
안녕하세요.
안녕하세요. Nice to meet you. Garcia. Yes, nice.
Yes,
Yes.
it's early in the morning for you.
Please permit the sharing is my
Your share
laptop.
your screen. Yes, I will.
Yeah.
Okay, you're able to share your screen now.
Okay, thank you.
And
Okay, first topic. Yes.
yes, let me fully give the opportunity of Felix to present you, and we'll start right away. Okay, we're going to start recording this
Yeah.
meeting.
Okay.
So it's I'm going to count down from 3, 2, 1. Okay, we just
Okay.
started recording.
Yes.
I would like to thank you all for being here. Muchas gracias a todos nuestros participantes de la República Mexicana y de otros países que nos acompañan en esta tarde. Para nosotros es un gran honor tener al doctor Hwa como invitado especial para cubrir algunas de las temáticas correspondientes al módulo 3 de nuestro diplomado. Y bueno, por el perfil académico tan importante y la importancia de nuestro ponente, decidimos hacer esto un evento abierto para que todos puedan de alguna manera participar y que también vivan la experiencia académica que nosotros estamos logrando a través de este primer y único diplomado con reconocimiento universitario en la República Mexicana y además con una certificación de Spinea Latinoamérica. Spinea es Endoscopic Spine Academy. Voy a compartir algunos datos sobresalientes del doctor Hwa y voy a dejarle la palabra a Félix. Dr. Hwa, I'm going to share my screen very briefly just for your presentation.
Yes.
I have some important aspects from your CV.
Okay.
There we go. Dr.
Yes.
Hwa
Here. Yes. Okay.
has
Thank you.
two, well, more than two topics of interest, obviously.
Yes.
He's
Okay.
very skilled in minimally invasive spine surgery. Main interest is biportal endoscopic surgery and endoscopic fusion surgery. He's
Okay.
main author for Unilateral Biportal Endoscopic Spine Surgery textbook and has participated in multiple papers and also two other textbooks related to endoscopic spine surgery, both in the spine surgery and cervical and thoracic spine surgery. So I'm going to give the opportunity to Felix to introduce you properly. Félix, adelante. Voy a dejar de compartir mi pantalla.
Oh, Dr. Heo, thank you for being here, Professor, and for accept my invitation and the invitation of the Spine Group. That is the only training that is supported by a university diploma in Mexico, training in endoscopic spine surgery. It's a pleasure to have you here. I met you the last year in Amsico, and then we went to your hospital for a week a couple of months ago. And of course, you are one of the most important surgeons in biportal endoscopic spine surgery. So it's a pleasure to have you here. And thank you. Thank you again for accept this invitation.
Start?
Yes, you can start. Yes, sure.
Yes, okay. My name is Hwa Heo. Thank you for invitation. So it's my honor to present my topics. 15 years I started the endoscopic spine surgery. At the time I start full endoscopic surgery. Recently, totally moved to bipolar. So I prepared two topics. The first topic is the bipolar, the posterior cervical foraminectomy and discectomy. So I start basically the technique of the bipolar endoscopic PCF is very similar to the microscopic surgery. So just we use
I'm sorry, Dr. Childenwa, you can share your screen, please. Share your screen
Yes.
again.
Oh, okay,
Yes.
okay, okay, yeah. Okay. Can you see my
Yes, I can see your screen.
yes,
Perfect.
okay. So yeah, basically the bipolar endoscopic posterior foraminectomy is very similar to the microscopic approach, also very similar to the full endoscopic approaches. This is my positions. Yes, neck is slightly flexions, and also neck is slightly flexions, and the shoulder is slightly retracted for, and we have to making two portals. So in the AP view, so we make the two portals in the middle line of the pedicle line. So this is a rear CM fluoroscopic view. So we have first dominant hand we made for the endoscopic portal. So for the dominant hand, so we made for the walking portal. Yes, we have to use the two portal. So this is another view. So sometimes the lower level, C6, 7, or C17, or sometimes barely the difficult for the checking the level. Sometimes we use the contralateral oblique view. We can easily check the low level of the cervical foraminectomy. And some 71 levels, so 6, 7 levels, sometimes very difficult to check the level. However, if you use the COV view, we can easily check the C71 level like this. So this is my overview. Undominant hand only used for the viewing portal. So the other dominant hand, we use the working portal for the insertion of the rear operations instruments like this. It's very similar to the full endoscope or microscope. Firstly, we have to check the viewpoint. That consists of the lower lamina and the upper lamina level. And then, so we have to full decompressions like the microscope approaches. So I always try to the full decompression from pedicle to pedicle. And the laterally, I always decompression medial pedicle border to lateral pedicle border. So this is a result in the 50% resection of the facet. Now I will show my case. This 45 years male patient presented severe left arm radiating pain. You can see there the foraminal disc herniations. So my decision is the posterior foraminectomy with the discectomy using the bipolar. So firstly, we have to check the V-point like this, and then start the drill. I prefer the diamond drill. And then also you can see there the C6 lamina and C5, 7 lamina. Basically, this technique is very similar to the full endoscope PCF or the microscope PCF, just using the bipolar approaches. This is a facet of the C6. I full exposure of the C6 and 7 lamina, and I did try to the drill paper thin pattern. I changed to the 2.5 millimeter small diamond drills. You can see there IAP, and after the paper thinning of the bone, and then I remover of the bone wall. This is a pedicle. Just to use the very 1 millimeter or 1.5 millimeter diameter the kerosene launcher. I full exposure of the membrane and the ligament flavum, and then just to remove of the ligament flavum and the lateral part, we can meet the epidural vein. Also, we can see the dura. After coagulations, this epidural vein and membrane and the remover of this part, finally we can see the dura and then the nerve root. As you know, the cervical nerve root usually consists of the two nerve root. This is a sensory nerve root. And the removal of the membrane and the adjacent tissue, finally we can see the full exposure of the nerve root. This is a sensory, this is a motor nerve root. This point is the pedicle, sensory and motor, axilla, and then exploration of the axilla. And sometimes I cut the membrane. Finally, we can easily expose of the rupture disc herniations like this. So important point of the endoscopic PCF, firstly, full decompression of the bone structure and full exposure of the nerve root, and then exploration of the axilla area. And then also I did perform the complete azoliolysis. This is a pedicle of the C7, C6, and C7 pedicle, pedicle to pedicle, medial pedicle to lateral pedicle. That is my end point, and also explorations of the axilla again. Pedicle to pedicle, medial pedicle to lateral pedicle border. Sometimes I remove of the osteophyte using this very small size of the curettes. And then that is the final view. So bipolar, we use the 4 millimeter diameter, the endoscope, very we can see the very clear and as a clear and precise demonstration of the surgical field. That is very important point. After surgery, you can see the complete decompressions of the cervical foramen, and we complete removal of the rupture disc herniations. So we always, as you know, so we always check the sensory and motor nerve root, and then after exposure of the full decompression of the nerve root, and then exploration of the axilla, and we can easily expose of the axilla, and then move to removal of the rupture disc herniations. I will show Another cases, you can see the similar foramen stenosis and the central stenosis, and also you can see the ruptured disc herniations of the C5, 6 right side. So this patient recommended the hospital 3-level HDF. However, this patient reject. So my decision is only the foraminotomy and discectomy. So exposure of the right side approach, the C5 and C6. First exposure of the V-point firstly, and then the paper thin pattern, the drill. I will prefer the 2.5 millimeter the diamond drill. And then I did the medial foraminotomy, medial fascectomy, and you can see the uh, membrane and ligament flavum, and the removal of the ligament flavum and the severe adhesion tissues. Right, this you can see the very severe adhesions, and I also of the lateral part of the ligament flavum. Finally, we can expose of the nobled. You can see the severe adhesions, and I did a adhesive lysis with the exposure of the axilla area very carefully. And full exposure of the axilla area. And also you can see the medial part of the pedicle. So what is that? This is the not rupture disc herniation. This is a sensory and this is a motor nerve root. Yes, full exposure of the nerve root and carefully dissections of the axilla area. We can finally meter. This is a sensory. This is a motor nerve root. Finally, we meter rupture disc herniation like this. Also, explorations again. Yes. Finally, you can see the full decompressions of the nerve root, sensory nerve root, and motor nerve root, and complete removal of the rupture disc herniations. Yes. After the post-operative MRI reveal the complete resection of the rupture disc herniations. We always we have to check the motor and sensory nerve root like this. And another case is if patient have the severe foraminal stenosis, we have to check the pedicle medial border and superior border. I will show right side approaches. You can see the severe adhesions around the dura and the nerve root. Sometimes very nervous. After resection of the severe tight band and adhesion tissue, finally we can meet the dura and the nerve root here. Sometimes very difficult to distinguish the dura and fibrous adhesion tissue after exposure of the axilla, and then I can remove nerve root, rupture disc herniations. This is the end point of the nerve root. Yes. So sometimes we always have to check the possibility of the multi-fragmented disc particle. You can see there, firstly, exposure of the axilla. You can see the rupture disc herniations firstly. You can see the motor and sensory nerve root. I'll remove of the first ruptured fragment. The view is very nice. So we use the first. I'll remove the first ruptured disc. Is enough? No. I will check the explosion again. I'll remove second particle. Also, I'll remove of the another particle. I check the axilla area. You can see the another rupture disconnections. I'll remove a third. And also I'll check the axilla area again. Yes, I'll remove fourth and the fifth. Is it enough? Our exploration again. Sixth particle. Yes, that is the end point of my PCF. So we always consider the possibility of the multi-fragment disk rupture disk. I put in the gel form. Yeah. And if patient have the severe foraminal stenosis, we have to cut the SAP tip for the complete decompressions. You can see the severe adhesion around the root. This is a SAP tip. So hypertrophied SAP tip should be removed for the complete resections and complete decompressions of the foramen. Yeah. After resections of the, we can fully expose of the nerve root. We can the decompresses from the pedicle to pedicle. Yes. After now I remove of the severe adhesion tissue. You can see the sensory and motor. So we have to cut the SAP tip like this for the complete decompression of the nerve, cervical nerve root. And I will show my video again. Firstly, expose of the V-point, and then I drill the paper thin, and you can see the SAP and cut of the SAP tips. After resection of the SAP tip, we can decompress fully. After removal of the SAP tip, you can see the severe adhesions tissues and ligament flavum. This is the medial part of the pedicle, the pedicle to pedicle, and I also did a partial pediculotomy for the complete decompressions and the exposure of the axilla area. Maybe yes, this point is the medial border of the pedicle, and then exploration of the axilla area, and then the removal of the rupture disc herniations, and then sometimes I remove the posterior, the osteophyte and adhesion tissue like this. So removal of the rupture disc particles. Firstly, we expose of the dura and nerve root completely, and then exploration of the axilla areas without our excessive retraction of the dura and nerve root, and then final removal of the rupture disc herniations. So pedicle to pedicle, medial pedicle to lateral pedicle decompressions was performed. So after surgery, you can see the severe foraminal stenosis was completely decompressions using the bipolar approaches like this. So sometimes we meet the severe adhesions. We call the posterior epidural membrane or fibroareolar tissue. This is the dura or the membrane. Sometimes very nervous. This you cannot see the epidural vein. This is the not dura. This is fibrous band. After the cutting of the fibrous band or the thickening of the posterior epidural membrane like this, you can see the severe clear the dura and the epidural membrane. For the complete decompression of the nerve root, we have to cut the posterior epidural membrane or the fibroareolar tissues. Sometimes we have to check the presence of the posterior epidural membrane like this. So after removal of the posterior epidural membrane, and you can see there the posterior epidural vein, and then you can see the clear the dura. So posterior operative skin is very small. Yes, I just the size of the length of the skin wound for the viewing photo only made just 5 millimeters, and the working photo I made 7 or 8 millimeters. Yes, very small size of the skin wound was presented after bipolar endoscopic surgery. So this technique is very familiar to spine surgeons. Yeah, so because this technique is very similar to the microsurgery, the surgical landmark is very important for the complete decompression. I always check the pedicle to pedicle and the medial border pedicle and lateral border pedicle. I always remove of the fibroareolar tissue. Some doctors call the posterior epidural membrane, and the complete decompression of the foramen, and then the exploration of the axilla area. This pattern of the technique, we can easily and we can safely perform the bipolar endoscopic posterior foraminotomy and discectomy. Thank you. Yes, so that is my first presentations. Okay. Do you have any other questions?
Vamos a hacer una pregunta. El doctor Hwa abre el foro para hacer preguntas. Thank you, Dr. Hwa. I just translated to the group that if they have any questions. You only showed us single level. Do you have any? Yes. Do you have any tips for multiple level? Let's say maybe 2 levels or even 3-level decompression on one side or the other?
Yeah. So we call the sliding technique. Only one pair the approach we can achieve the 3 level. So sometimes I did only one pair the approaches we can achieve the 2 or 3 level posterior foraminotomy. We call the sliding technique. We can, yeah.
With the same 2 incisions on the fascia, just
Yeah. Say only
like the instruments.
one incidence we can achieve 3-level decompressions.
Thank you.
Yep.
Yes, Dr. Heo, I have a question. Well, first of all, I think it's a very good tip to use the oblique projection when you are
Yeah.
planning your trajectory, especially in operating room, because it's not easy sometimes to check, especially C6, C7, C5, C6 is better, or upper levels. I think it's a very good tip. And my question is first, do you think that we need to view always the both part of the nerve root, the sensory one and the motor one? You always dissect all the membrane and see both part of the nerve root?
Yes. So patient has a long history of the radiating pain. Most of patient has the severe adhesions. So for the complete decompression of the nerve root, I believe we have to cut the posterior the adhesion tissues for the complete decompressions. Yeah.
Okay.
Yes, after resection of the posterior epidural membrane or adhesion tissue, we can achieve the exposure of the axilla area. After decompression of the nerve root, and I always check the axilla area, the presence of the ruptured disc herniations. Therefore, I believe we have to cut the posterior epidural membrane or adhesion tissues.
Okay, great. It's very difficult to distinguish between the epidural membrane and the real
Yes,
dura,
that's very nervous.
especially for the nerve. Yes, nerve root.
Duras or membrane, something. However,
Yes,
distinguish the point is differential point is the presence of the epidural vein.
epidural vein. Yes.
Yeah.
And last question: only when you planned your surgery, did you use oblique views in MRI for analyzing especially in foraminal stenosis,
Yes,
cervical
yes,
spine?
yes.
Always?
Our institute routinely check the foraminal views of oblique sestal view for the uh, diagnosis of the foraminal disc herniations and foraminal stenosis. Yes.
Great. Yeah. ¿Alguna otra pregunta? ¿Alguien?
So I prepared the presentation of the thoracic ORF. Okay,
Yes.
I start. Okay, yeah.
Please go ahead.
Okay, my second presentation topic is the removal of the thoracic ossification of the ligament flavum using the bipolar approaches. Okay, so this is a lumbar. This is a thoracic area. So the lumbar approaches, the contralateral decompressions should be performed by the sublaminar approaches. However, very different. In thoracic decompression, we did unilateral approaches and bilateral full decompression of the lamina. So very similar to the subtotal laminectomy. However, comparing to the lumbar area, so contralateral decompressions was performed sublaminar decompressions. However, in thoracic or cervical area for the decompression of the central stenosis, so translaminar decompression, full decompression of the contralateral lamina is different point comparing to the lumbar area. And the easily and safe performed of this approach for the thoracic decompression, we have to use a two hands technique. So you can see there, I control the third long finger. This is the self endoscope retractors. If we use this endoscopic retractor, we can easily and safely perform the contralateral and ipsilateral decompression and the removal of the ossification of the ligament flavum. I will show this 74 years male female patient presented severe tingling sensation of the bilateral leg and weakness of the both legs. You can see there's ligament flavum of the hypertrophy and ossifications, and the resulted in severe stenosis of the T10, 11 levels. So my decision is the decompression and removal of the OLF using the bipolar. I will show left side approaches. Yes. Firstly, exposure of the lamina and the drill of the superior lamina. Also, I prefer the diamond drill. So first approach is very similar to the lumbar area, and this is the midline, the basement of the spinous process. Excessive of the removal of the spinous process space. This is a contralateral lamina. In lumbar areas, with the decompressions of the sublaminar decompression, we can control the retraction of the dura. However, in thoracic area, we cannot retraction of the dura. After of the ipsilateral aminotomy, you can see the SAP, and also you can see the ORF. And then I perform the medial fascectomy using the small diameter of the diamond drill. This is the lamina. Also, we have to remove the lamina paper thin pattern using the small diameter. After partial resection of the soft ligament flavum, and you can see there, this is the OLF, and OLF mass is connected with the SAP. And then lower lamina, superior level also. You can see there, this is a endoscopic retractor. I retract soft ligand flavum partially using the endoscope retractor. This point is the SAP and lower lamina. We have to drill the paper thin pattern. Very different, and also we can see there dura. Now I did a medial fastectomy. I only 1 millimeter diameter the Harrison longe using, and this is a contralateral side. Now I remove of the lamina firstly. You can see the epidural, the vein, and epidural, the fat. This is a contralateral side. So very different from the lumbar level or kinds of the subtotal laminectomy. This is a contralateral SAP. You can see there very, yes, ORF mass. Where ORF mass was severely adhere. So ORF mass was retracted using the endoscopy retractor, and then I dissected severe adhesion plan, the holding the ORF mass using the self retractor, and then removal of the ORF mass. Yeah. And then we can, now I move to the contralateral side, and then removal of the hypertrophied ligament flavum, and then also removal of the ossifications without any indentation of the dura and spinal cord. I remove the remnant ligament flavum, and also I decompressed more laterally, exposed of the lateral body of the nerve root and the dura. You can see the complete decompressions and complete removal of the ORF. So different from the lumbar techniques. Also, I will show again. So post-operative MRI shows complete decompression of the central canal and complete resection of the ligament flavum. I will show another case. You can see the severe ORF and stenosis of the thoracic level. After laminotomy, now I drilled SAP. ORF mass is connected to the SAP. The retractions of the ORF mass only without any indentations or the retraction of the dura. And then I use the self retractors. I hold the ORF mass using the self retractor, and then dissected the plane of the between the ORF mass and the dura. We can very safely remove of the ORF. Post-operative MRI shows the complete resection of the left side ORF mass like this. So in cervical area or thoracic area, we prefer the TWENS technique of the bipolar. So we use the endoscopic self-retractors. So wound post-operative is very small. So we only two-step wound using. So we completely resections of the ORF mass and complete decompression of the central canal of the thoracic levels. So if you use the UV technique, we can easily and safely perform of the list and the decompression of the thoracic level. And also I recommend the TWENS technique using the endoscopic self-retractor. So if you use the TWENS technique, we can safely and easily perform the thoracic decompressions. Okay, thank you.
Thank you very much, Dr. Hwa. ¿Alguna pregunta para el doctor?
Dr. Heo, Professor,
Yes.
Just another one question. You know that in biportal endoscopic spine surgery, triangulation, it's a very, very important point.
Yes.
So where is the triangulation point in thoracic spine? And is this
Yes.
different in the lower levels compared to the upper levels?
Yeah. So the main target is important. However, most of the simple point is lower lamina of the lower point of the lamina of the superior level. If we perform the 10, 11 decompressions, my docking point is at lower T10 laminar. Very
Okay.
safe and easy. Okay.
Wow.
Para los que no comprendieron muy bien, el doctor Félix pregunta que cuál es el punto de triangulación en la técnica biportal para el segmento torácico y es el borde inferior de la lámina superior, o sea, pues sí, van a estar entrando en el espacio interlaminar y en este caso, si entran entre T10, T11, es el borde inferior de T10.
Yes. Wow.
¿Alguien más? ¿Alguna pregunta?
It's another comment or maybe question, Professor, is I know that you, before starting doing biportal endoscopic surgery, you perform many procedures with uniportal or full
Yes, right.
endoscopic procedures.
Yeah, yes.
And especially in cervical spine, do you think there is a difference between both procedures, or which one for you it's easiest or better?
Yeah. So in the unipolar, the good advantage for the discectomy. However, recently the indication of the endoscopic spine surgery moved to the stenosis or instability. So we have to do the bone work. In aspect of the bone drilling, it's much easier than the bipolar comparing to the unipolar. So therefore, I totally moved to unipolar to bipolar.
What
Okay.
problem? Yeah.
Yes.
Yeah. Right.
Maybe I'm going to go Cancun.
Yes. Yeah. We are
So,
waiting for you. Yeah.
MC core. Yeah. Okay. So I
Yeah.
really want to meet the Dr. Feliz and Garcia. Okay. Yes.
Okay. Perfect. Yes. Yes.
Thank you for
Great.
invitations. It's my honor to today's to present my lectures. Okay. Thank you. Thank you again. Okay.
It's
Thank you
an
so
honor for
much.
us.
Thank you.
Thank you very much. Yeah.
Keep in touch. Goodbye.
Bye bye.
See you
See you in Cancun.
for
See you
sure.
in
Yes.
Cancún.
No sé, algún
Vale.
comentario, preguntas.
Sí, dejaré abierto el canal unos 5 o 10 minutitos más. Si alguien quiere discutir alguna de las dudas, comentarios.
Pues creo que este último comentario de él se cierra mucho a lo que hemos platicado entre nosotros también, ¿no? En la parte biportal ayuda mucho más en pacientes con estenosis y la uniportal más hacia esas hernias de disco, ¿no? Creo que es un comentario similar.
Sí, yo estoy de acuerdo. Creo que el punto que tocó y que siempre he pensado que es algo que agrega dificultad al procedimiento endoscópico y no que agregue dificultad, sino que necesitas una mayor experiencia en endoscopía, es el uso de la fresa. Y creo que sí, el fresado en el biportal es mucho más cómodo y creo que mucho más rápido y consigues quizá mejores descompresiones. Yo estoy en ese inter de decidirlo, pero sí, el fresado me parece como fundamental en hacer una u otra técnica dependiendo la patología, ¿no?
Sí.
Bien. ¿Alguien más? Ok, pues
Yo,
hacemos
una,
una.
ah, yo-
Sí,
una-
adelante, Miguel Ángel.
perdón, nada más una duda. Así como él dijo los puntos de entrada a nivel torácico, a nivel cervical usamos igual los bordes inferiores de la lámina superior para
No,
trasladarlos.
en el nivel cervical, tanto en biportal como uniportal y técnica abierta, me encantó la comparación que hizo el doctor. Es exactamente lo mismo, es
La B.
el punto en B es correcto.
Ok.
Y ya ahí, si quieres utilizar la referencia que dio el doctor Félix en su clase,
Ujú.
va a variar de patología a patología, qué tan lateral te tengas que ir a partir de ese punto en B. Eh,
Ok.
ese es definitivamente un punto anatómico fijo, pero el punto en B puede variar de manera positiva o negativa de acuerdo a qué tanto hueso necesitas quitar a nivel lateral. Yo creo que uno de los aspectos muy importantes que remarcó el doctor Hwa es, y esto es un mensaje muy bueno para llevar a casa, la descompresión de pedículo a pedículo y de cortical medial a cortical lateral, ¿no? Entonces, de esa manera ya están ustedes 100% seguro que no se llevaron más del 50% de las facetas y que ese foramen está descomprimido. Y si a eso le agregamos en la estenosis severa, pues es la descompresión del proceso articular superior, ¿no?
Ok.
Y de hecho, la plática del paso a paso del abordaje cervical que ayer intentamos, que la grabamos, pero no se grabó el sonido, ya que la subamos hoy más tarde, en cuanto puedan, revísenla y ahí vienen como más detallados esos pequeños detalles que hoy el doctor tocó de manera
General.
muy general.
Ujú.
Y en la columna torácica, lo que yo he visto un poco en mi experiencia, también hay un punto B que viene siendo esa yuxtaposición de las facetas. Y normalmente el punto B coincide con el borde medial del pedículo inferior. Por lo menos en uniportal es una buena referencia para las laminotomías torácicas. Eh, pero sí era muy importante tratar de entender dónde triangulas en en la columna torácica.
Ok. También lo que yo entendí es que a nivel o sea, a nivel torácico, la descompresión contralateral, él la hace, digamos, más transapófisis espinosa, o sea, se lleva más apófisis espinosa que... Eso fue lo que yo entendí, que a nivel lumbar, fue lo que él mencionó.
No sé si alguien quiera comentar.
Sí,
Alfonso.
sí, él se refirió como translaminar, él lo refirió de esa manera. A
Ujú.
nivel torácico, el espacio interlaminar es nulo prácticamente, la superposición de las láminas es muy importante, entonces casi toda tu recepción es a través de la lámina, es una abordaje netamente
Translaminar sería más correcto, ¿verdad? Que
translaminar.
transespinoso. Ujú.
Entonces, es lo que quiso decir el doctor Giodonwa con los ejemplos que nos
Ok.
puso, ¿no? Algo que hacemos cada vez con mayor frecuencia es ese tipo de resección que él resaltó. Bueno, a mí me gusta llamarle cáscara de huevo, o él le llamó
Hoja de papel, ¿no?
hoja de papel, es
Mm.
correcto.
Ujú.
Se me hace una medida muy segura. Ustedes van resecando hueso hasta que está prácticamente transparente y lo pueden utilizar de referencia para ir guiando la resección, ¿no? Entonces, eso, por ejemplo, a nivel cervical es súper importante para que no se
Ujú.
lleven de manera excesiva el pedículo, que son muy pequeñitos. Y a nivel torácico, honestamente, no tengo experiencia con abordajes interlaminares, entonces ahí me quedaría corto en hacer comentarios. El doctor Félix ahí tiene más experiencia. Pero yo creo que una regla muy general para resecar hueso y muy segura es precisamente adelgazar el hueso hasta un grosor de papel o cascarón de huevo.
Gracias.
Sí, lo que yo entendí de este abordaje translaminar, Miguel, es que en la columna lumbar no tienes mucho problema en irte con la técnica over the top porque tú mismo vas haciendo compresión sobre el ligamento amarillo y vas fresando el borde de la lámina, ¿no?
Mm.
O la cara ventral de la lámina. Acá en la columna dorsal y en la columna cervical, pues tienes médula espinal. Entonces, el hecho de irte translaminar, es decir, te vas por el hueso
Oblicuo,
para
por así
romper la cortical y
decirlo. Ok.
entonces encontrarte el ligamento amarillo de arriba y después empezarlo a disecar gentilmente con el disector, de tal forma que no haces ninguna
Presión que
compresión
apoya. Ok.
ni nada sobre el saco dural. Ujú.
Ok. Gracias.
Y yo creo que también, Félix, no sé, ustedes corríjanme de lo que preguntaba Miguel de la referencia, también hay que tomar mucho en cuenta el nivel y la edad del paciente por la distribución del saco oral, las zonas de ensanchamiento, que también los puntos de referencia son referencia, pero ahí puede ser un primer punto de pérdida de su ubicación al encontrar más ensanchado el saco en los diferentes niveles de la columna cervical, ¿no? Creo que eso es un punto no solo de referencia, sino también de atención o de seguridad para, para esas primeras descompresiones posteriores, ¿no?
Ok.
De acuerdo. Ujú. Sí. Yo ahorita que vi los videos del doctor, sí he tenido algunos casos donde veo las dos ramas de la raíz, pero regularmente veo solo una. O sea, no quito toda esa membrana como él lo dijo, porque verdaderamente en algunos casos es muy difícil distinguir si es el borde de la dura madre o realmente es esa membrana. Y en uno de los primeros casos que yo operé cervicales, no encontré la hernia, y básicamente no encontré la hernia porque quedó libre la raíz, se veía el saco. Como es una imagen biplanar, no tienes profundidad y simplemente me faltó terminar de abrir esa membrana para poder llegar al defecto. Entonces, esa parte yo la tomaría siempre con cierta reserva, pero efectivamente hacer esa membrana que se tocó muy bien en la primera charla de anatomía es fundamental para poder tener una buena descompresión y que verdaderamente esto se traduzca en mejoría del paciente. Sí. ¿Qué más?
Bien, bien. No sé, ¿alguien más, alguna otra pregunta? Y si no, casi, casi vamos a entrar como que en receso 3 horas para la siguiente, que viene el doctor Kang Tek. Él se va a conectar desde Uzbekistán. Eh, Ahí está ahorita él. Van a ser las 8 de la mañana para él cuando inicie la plática con nosotros. Ok, entonces vamos a
Bien.
concluir esta tarde. Nuevamente, gracias por conectarse. Están invitados a conectarse nuevamente a las 8 de
A
la
las
noche
8.
y mañana los esperamos en el taller, los que se anotaron para el, el turno matutino y el vespertino. Ok,
Nos
listo.
vemos al rato.
Gracias.
Gracias. Hasta luego.
Muchas gracias a todos. Gracias.
Gracias a ustedes. Gracias.